So thank you very much and welcome to you all. So the group of you went to InterMountain to take this quality improvement course. I understand that was a pretty significant commitment on the part of your, in terms of time, energy and even financial resources. There are a lot of years of experience and perhaps a bit of skepticism sitting in this room today. Is there anything that you learned there that makes you think that there is something in what they do at InterMountain that the profession here should similarly invest time and energy in, or is this just the next fad that will pass in time?
Maybe I'll start us off. For many of you, you probably don't know where InterMountain is or what InterMountain, the Institute for Healthcare Improvement, is doing. So this is a network that is within the state of Utah that covers a population of roughly equivalent to the province of Saskatchewan in a network of healthcare facilities, both acute and chronic. So very similar in many ways to the province here. It was interesting to go visit there and attend the course because they have individuals from all across the United States come to that course. And you can see first of all, the mandated requirements for quality improvements that are occurring across the United States. Pay for performance, which we've heard, accountability care organizations, or ACOs as they will use. So you can see that as part of the mandate, but as well, it was very interesting to see the extensive involvement of physicians within that facility. And then when you meet with them, you hear that many of the same challenges that they have perhaps different levels of urgency for what they're doing. And they have the same challenges, but how much progress was presented at the end of the course in their problems and in their work that they've done. So it was really very interesting to see and to gain the expertise from individuals that are coming together and sharing information. And I think they're very open about it. They're very willing to share, so that was very positive. And we recognize that they can do much better by learning from everyone across as a participant as well as from their own network. So it was really quite an exciting time from that perspective.
Thank you, Paul. Anyone else?
So I would like to just start by thanking the Health Quality Council for sponsoring me to go on this learning opportunity, because I've learned quite a lot. Because I've been involved with quality improvement for quite some time, but even going on this trip and participating in it and doing the actual work of going through a quality improvement project, the thing that struck me the most was the notion of moving from craft-based medicine to the science of medicine. What I mean with that is we know that there's a lot of variability in practice out there. We know that from research and evidence that is out there, not only in our province, but across Canada. There's a lot of variability in practice that is well beyond where you can accept that every single patient at every single visit will get the highest quality of care. And we know that there's not only variability in the care that the patient would receive when they go from one physician to another physician, but there's also variability in care with the same physician. And what I mean with that is when the same physician sees a patient, when they are well rested, after a weekend, during office hours, that care might differ when they see a similar patient when they have been on call for quite some time. It's in the middle of the night and there's a large volume of people that need to be seen. So there's not only variability of care between the different providers, but also between on one provider at different points in time. So what one wants to do is one wants to get away from craft of medicine where we are individual craftsmen. And what we want to do is we want to look at those conditions for which we have the evidence and what we know that there is best practice out there, and put systems and processes in place so that whenever a patient touches the system, doesn't matter where they enter, doesn't matter which locality in the province, which provider they get to, they will get the same high quality care. We would still have the responsibility as physicians to be part of that setup, of setting that up and getting those processes in place. And also, when we have those processes in place, a lot of people compare that to cookbook medicine. And I can absolutely confirm that it's not cookbook medicine, because the thing is, we need to be part of creating that and continuously evaluating it so that we can continue to improve it. And it doesn't mean that when you have a protocol or a standard out there, that you always have to follow that. Because the thing is, that is where the skill of a physician comes in, is to recognize that patient that should not be treated in that way, and you should then treat that patient maybe in a different way. But the thing is, when you apply the 80-20 rule, and people come and they touch the healthcare system, we know that 80% of the people that come will fall within the limits of a specific protocol. And those people, you will be able to treat with high quality care without having to think about it. And then the other small percentage of time, you will be able to use your skills as a physician to deal with those exceptions in care. And that is the move that I feel that we have to make, so that we get away from that variability between physicians, and also that I can know and be assured that when I see somebody, when I'm well rested, and when I see somebody in the middle of the night, the system and the processes that are out there are going to help me to be a better physician than that I am presently.
Sweet.
Why? Ask the question is, if we ask the question why we should be part of this or any of these things, is because we are entering into the world of complexity, and the systems in which we have designed, particularly the hospital system, is designed for a 3 or 4 decades ago, but it is changing. And the Minister of the Health today alluded today that how much of money that if we spend exponentially, other things in the society gets moved out. And if we were to think about that way, how do we make a sustainable healthcare system that last for the next generation, the following generation? We have to have some shared vision of developing providing the highest quality of care. And that is the only aim. If the money savings comes along with it, so be it. We've been able to deploy it from a different way. And if we were to think about that in a different concept, the subsequent to the alumni conference that I went to this February showed they have increases. What they talked about, the minister talked about is 6%. It is not 6% in InterMountain at this time. It's the cost of living. That's the only thing that they went higher. So they saved, out of the $2 billion budget, they saved $400 million in 4 years. And how did they achieve it? Is looking at the data, reducing the variation of practice, and also avoiding some of the things what we do. I was shocked, and when I went into the system, is when the data was presented, and it has been universally proven. Every time the patient comes into the hospital, the risk of an injury or a death is closer to, or harm for the patient is closer to 50%. And that means that every patient that comes into the system, even if you are going into the hospital, there is a risk. And how do we evaluate it? How do we treat it? Do we have the honesty for us to go and learn from this? Yes. And that is the reason why we needed to do that.
So I think my colleagues have covered many of the similar themes, and I think one of the additional learnings that I've got out of the InterMountain experience was really around the importance of data and the good quality data, and how do we get that data, how do we build that into workflow so it's not some extra work that we do. It's really a shift from, saying in my experience, this is what I would do, to in my measured experience. And I think a lot of us are surprised once we start doing quality improvement, like Shri and many here. I've been doing it for quite a while. Lean certainly added another toolkit to that, but when you look at it and you start actually looking at the data and you start, whether it's a chart review or anything like that, most of us are often surprised at what we see. And I think we want to believe that individually we're always doing the best job we can, and we certainly want to believe that of our colleagues. And there is variation, whether it's because we're tired, because of resources available, because of how we were trained. And so how do we look at the data, not in a punitive sense to say, why aren't you doing this and how can you do this, but how do we use it as a way to say, what are they doing in Regina that they're getting those types of results? Is there something out there that maybe we didn't know about, and maybe a new process or a new way of doing something? And how do we take that opportunity to do that? Now, certainly the backbone of that and what InterMountain has is a really great data infrastructure. And so we had a lot of discussion around, which has to come first. We have the beginnings of good data collection. We're trying to get that better as we go along. But I don't think we have to wait until that happens. I think it's something that we start now, and we simultaneously try to build some good data infrastructure. I think when you see it, it is surprising, and it's about how you're approaching the data. Don't be afraid of the data. The data isn't meant to look at how do I make myself better? How do I make sure that I'm keeping up and doing the best I can? And what are some other ideas out there that can help me provide that better level of care? And I think the other big surprising thing for me is that InterMountain publishes. So, many of you know at our university, and I'm a university-based physician, that there's concern that we're not publishing enough and we're not competitive enough. And many of the reasons for that is that we're heavily clinically based. And InterMountain publishes over 200 papers a year in New England, JAMA, all these journals, with not one university-based physician on staff. These are all academics, these are all community-based physicians who have good clinical judgment, good clinical skills, and the stuff that they're publishing on is taking best practices and applying it and showing the change that they can do. So we're not inventing new things, we're applying it and providing better care. And I think that's really where we can excel in Saskatchewan. That's really where we can stand out, because we have good collaboration. And yes, we have to work on collegiality, but I think we can have those conversations with each other and say, how do we get this implemented? How do we do this and roll out and be able to talk about this nationally in other places? So I think it's a great opportunity for Saskatchewan to lead.
Try not to repeat things that have already been said. When I went down to InterMountain, I'd already been doing some quality improvement work, and for me, this is like, if I go back a decade or so, when laparoscopic surgery came in, it was this, this is one of the most exciting things that's happened in my career. And I have to say that this is now the most exciting thing that's happened in my career. And the reason for that is there was a few real aha moments for me. One of them is this is totally aligned with and in keeping with our professional values. It's about doing the right thing for patients. If you look between the lines a little bit of what they do in InterMountain, one of the big things, and I heard this today from our guest speaker in collegiality, it's about breaking down silos. They bring people together to talk about a topic that the clinicians think are important or the system thinks is important, and you don't just bring the surgeon together. You bring the surgeon with the physio, with the nurses, with whoever's doing that piece of work, and work out what is that shared baseline. What are we going to agree on? And sometimes there's a pathway and it's easy. And sometimes, there's no evidence, and we all know that. And it's about, okay, what are we going to do for the majority of patients with this problem in our system that then frees up the time and energy for the clinician to say, in this case, we're not going to do that because there's an extenuating circumstance. And then they look at that, and then they revamp it and make it better, and they continually do that. And so I think this is sort of the go-forward professionalism. It's us doing our best work when we work in this kind of fashion. I guess the only other thing I'd add is that it's about creating a structure for that. Like, we're already doing this. All of you are doing this already. There's standard order sets, and the intravenous DVT prophylaxis that happens. These things are already happening, but it's a mechanism or a structure by which we as a profession can just do this. It's like doing research. My colleagues all are interested in doing some research. They just don't know quite how to make it happen. And if they had the right support, they would do it. And not only do it, they do it with enthusiasm. And that's the same thing with this. I think that part of what this is, it creates, what InterMountain's done is create the appropriate structure and support to let physicians lead.
So thank you very much for those comments. Let me be the devil's advocate here a little bit and ask you that, is this maybe not a wolf in sheep's clothing? And is the real agenda maybe financial constraint, saving money and reducing service? 3.
Let me have a go at that point. The best way how we can describe ourselves, and Dr. Bill was earlier on talked about this, is if we take away the financial front end of it, outside the equation, and put the patient care at the best, some other times we will overspend than what we anticipated we will spend. That's perfectly okay. If we establish the only thing that we needed to do is the quality of care and the right care for the right patient at the appropriate time, over time, when the investment made is in the upfront is high and the quality of care improves, automatically the saving comes. I'll give you an example. One of the data points which I looked at is what is the longest stay in the hospital when I looked at it. It is the line infections and surgical site infections. And the line infection, surgical site infections increased hospital stay somewhere between 30 to 90 days in the system. So that means if I were able to identify the surgical site infection and reduce it, and if I have a bundle, or if I reduce the slide infection, what that would mean, the patient gets home, even if it is 5 days out of for every single patient of those. What that means, more patients of yours is coming into the system so that you can provide the appropriate care. So the cost is not the upfront. The cost is a byproduct of the quality. Is once you go, the savings starts to accumulate into the system for the betterment for other patients. So.
Thank you. Anyone else?
I'll take a second stab at that. Because what we know is that if we focus on quality, that most often we will have cost savings with that. And the cost savings that we have with that is by preventing rework. Rework would be people coming back after complications, people having had medication errors and that need to be corrected. So as long as we focus on quality, we should be improving cost. This is not something new. This is something that Deming had said when he was talking some decades ago. But the other thing that we need to keep in mind is we cannot focus on cost. Because the other thing that Deming had said is invariably when you focus on cost and cost cutting, invariably quality will go down in the end. So one has to focus on that quality component and make sure that we don't have the reworks, that we don't have the double work, and that we prevent those complications, because that is where the cost savings lie. And I think all of us know of areas where we can certainly improve things and take waste out of the system, because we don't have any other choice than to take the waste out of the system. Because right now, of every tax dollar that you and I pay, close to 50 cents of that tax dollar is going to health. And other parts of society like education, social services, roads, bridges, they also want part of that pie. And we can't continue to claim more and more of that tax dollar. So we absolutely have to do something on taking waste out of the system to curtail those costs. And the way to do that is with quality improvement. And that is where each and every single one of you in this room can play a role. Because when it comes to clinical work out there, we are the ones that can play a major role. And I believe that the taking the waste out of the system when it comes to the clinical processes is not going to happen when somebody else other than clinicians do that. So I feel that we have a very important role to play by recognizing where the waste is and taking that waste out of the system.
Thank you, Philip.
I'll just add one more thing. In a hospital system in the United States, which spends $3 trillion a year, 1.5 to 1.8 trillion dollars is a waste. And so, where is the biggest bang for the buck? So, if we had to ask for it as taxpayers, we should be concerned about it.
And I think InterMountain showed us that. So InterMountain switched from a model that was really focused on financial administrative model to saying, you know what, our business is clinical care. Let's focus on good clinical care. And they struggled at the beginning. So sometimes good clinical care didn't necessarily save money. It may have cost the same, but the quality was better. But with time, they were actually able to find savings and cost savings and money actually being used more appropriately. So they've done it. It's not a theory. It's not a, you know, in a perfect world, this is what would happen. They've actually gone from shifting completely away from our goal is to make as much money for our hospital as possible, our system as possible, or save money, to just providing really good clinical care. And lo and behold, they were able to save money. So.
Thanks, Jenny. Right, my last question to you has got 3 parts. So I've heard that there's a provincial appropriateness program. Do any of you know anything about this?
I'm probably the best person to answer that one. I'm the co-lead, one of the clinician co-leads of the provincial appropriateness program. Started this year, and it's sort of grew out of some work that was being done with the Saskatchewan Surgical Initiative previously, and a small piece of that was something called the Variation Appropriateness Working Group, and that's moved on. And it's built really on the same concept as InterMountain, where this first year we've just been working on developing a framework with an idea that there will be some projects that we do provincially in terms of creating the Saskatchewan way of doing something, and also supporting the regional health authorities in doing similar kind of work as they become interested in doing that. Deb Goodmanson is the administrative co-lead, and David Capriva and Regina is the other clinician co-lead. We're just getting nicely started, and our first project for this year is going to be around MR, so maybe Dr. Adam, you might want to have a word or two about that.
I'll add a little bit to Gary's comments. I mean, I think appropriateness is something that all our specialties and all groups of physicians have been doing. We're all aware of choosing wisely Canada, choosing wisely in the U.S. In my specialty of radiology, the American College of Radiology, as well as the Canadian Association of Radiologists, have been working for many years on trying to improve appropriateness. And we have the tremendous wealth of evidence now. And I think the issue for us as physicians, we have all this evidence, is how do we take that evidence and move it into our daily practice, and what are the best ways to do that? So these are new research areas, but at the same time, they're really important clinical areas for us to think about in terms of implementation science is part of what we need to learn, and how do we move that forward. And the provincial appropriateness program, as Gary has mentioned, is for surgery as well as for other specialties and physician groups. What we're hoping to do within medical imaging is to apply that to a few critical areas where the evidence has shown that there may be low-value studies being performed, or duplicate studies being performed, or studies that shouldn't be performed at all. And when we look at how we define what quality is in healthcare, obviously appropriate studies is the multiplier to whatever definition you use. So if the study doesn't need to be done, it has no value and no quality. And we want to improve our quality. We want to make sure that the study, first of all, has the value to that patient in that type of clinical scenario. So we're looking at low back pain and trying to improve appropriateness for that, and that was our project at InterMountain, but also a project that we're currently working on as a pilot within the Saskatchewan Health region. And I do think that this province has a great potential to lead in this area because we are a very focused collective of physicians that are hopefully can continue to work together and spread information from south to north and north to south within this province. And so with medical imaging, we're focusing on MRI, which will be appropriate as project number 1 for the province, and also for our health region.
Thank you, Paul. You mentioned Choosing Wisely and Choosing Wisely Canada. Do you not think that maybe the Choosing Wisely campaign and this appropriateness program are in competition?
Not at all. I think if you look at all of the Choosing Wisely, it's a list of recommendations by the various specialties, or typically their top 5, or if the second year, top 10 things that physicians should think about not doing. It's one thing to have a list, it's another thing to put that list into action and reality, and to assess how well we're doing. And I think we have to move beyond thinking we're good to showing we're good, and demonstrating our quality, and demonstrating not only to our payers but to our patients how well we are doing for them against metrics that may be national and international coming forward.
I agree with that. The other point I make is that we are, the provincial appropriateness program is in conversation with the SMA. There's no intention to be competitive with the company.
Okay, so again, being the devil's advocate, if one talks of all this appropriateness and appropriate care, so the knee-jerk reflex is, are we then practicing inappropriate care? And is there maybe a suggestion that we are not currently providing good care for our patients?
I'll start us off. Just, I think if everyone looks at the care they provide, they certainly know times when they could have done better. And when you get together with your colleagues, often within medical imaging, we'll show cases from one to another. And I always learn from my colleagues. And I think that as a group, we are collectively much smarter than as an individual. And we know, recent books like crowdsourcing and the wisdom of crowds and other things that we can learn from each other and improve what we're doing. So what we're hoping is that we can reduce unintended and unnecessary variation and ensure that best practice is the starting point for our offering to our patients. So in some sense, yes, we're making excellent care currently, but we certainly can do better from wherever we're starting. There's always room for improvement, and the way to do that is by working collectively together and building in a formal structure so that we can learn from each other as we move forward.
Three?
Just one other aspect is, I was shocked and also dismayed to learn that for every physician to function at the highest level of functioning, they had to be reading 20 articles a day, 7 days, 365 days, because that is a rapid publication of standards and newer care or other modalities of care is appearing in the system, and it is not humanly possible for us to even keep up with it, and that is not possible. So if we were to think whether it is what was appropriate tomorrow or today will be inappropriate in another week or 10 days because something new data is appearing in the system. So we need to be rapidly be able to respond to it. So it's not suggesting that.
Jenny?
I think a good analogy for that, for me at least, is when I have residents rotating with me. And, residents challenge you. Why do we do that? Or how come we do this? And a lot of times that's a very good question. You should look that up and we should discuss this tomorrow because, you're a resident and I don't want to just tell you the answer. Well, half the time, I'm sure I'm not the only one, everywhere I am, I don't know the answer. So part of that is that collegiality of discussing and being open to say, I don't know, is there a better way? And not only are our colleagues, whether they're our resident colleagues or our other colleagues, bringing their clinical practice, but they're bringing pearls that they've learned from other people, conferences that they've gone to, better ways of doing things that may or may not always be published. And so really, this type of exercise is to say that, is to bring people together and say, is there a better way to do this, and how do we do it better? So it may not be bad care, maybe the best care that we were taught or what we know, but there may be a better way, and this is an opportunity to look at that and to figure out a way of giving that to our patients.
And if I could just give one little analogy, one little story, and we haven't got time to go over all the different tools and methodologies and everything that Intermountain used, but if I think back a few years ago, doing screening endoscopy, we now do the fit test, but so what is the guideline again for screening colonoscopy? And I just can't remember right now, so I'll go ahead and look that. And it was a complex guideline, and I couldn't remember. At one point I had it stuck by my desk so I would remember. In Intermountain, they would build that right into your booking system so that you didn't have to remember it. It was there. You ticked off, these are the criteria. For sure enough, you go get your colonoscopy. And so that would be one little tool that they would use. And I think those are the little things. It's not that we're trying to be inappropriate. It's that we could do things that make it better or easier for us to do the right thing.
Thank you very much, Gary. So thank you very much. That sort of concludes my formal questions.